So welcome to this KDIGO webinar on the Controversies Conference on Glomerular Diseases, which deals with a conference that we organized late last year in Singapore to identify the areas of uncertainty that we have in the treatment of glomerular disease, and in particular to look at what is different compared now to the guidelines that are largely based on knowledge before 2010. And this conference is meant as a starting point to revise those guidelines. And in fact, this revision will start in August of this year. So I'm happy that Brad Rovin has agreed to cover this conference, which is quite a formidable task, to cover a 2-day intense conference in the next 30 minutes or so. So Brad, you have the word.
Okay, well, thanks, Jürgen. So hello, everyone, and at least in the United States, good morning, but I realize that that's not true everywhere. So this was the photo of all of the participants in the conference. Some you may recognize, some you may not. This slide shows you the people who led the breakout groups in the various categories of glomerular disease that we covered. This is going to be very difficult to read, but basically we compiled all of the recommendations from the original KDIGO guideline that was published for glomerular disease in 2012, and we indicated which of these were going to need revision. And as you can see, it's almost all of the guidelines. So this revision job that we will take on in August and hopefully provide you later. Hello, can you hear me? Okay, so and hopefully later in the year or in early 2019 should have very nicely updated recommendations. So let's get into some of the items that we discussed during the Controversies Conference, and we do want to wrap this my part up in about 30 minutes so you all have time and Jürgen has time to ask some questions that I think will be interesting based on these provocative ideas. Okay, so in terms of the general management of glomerular diseases, there is some question as to whether or not the kidney biopsy is still relevant for the diagnosis and management of disease. And the answer to that almost unanimously was yes, it remains an essential part of management of a disease. The need for electron microscopy, which is not uniformly practiced by all pathology centers throughout the world, remains controversial, and there may be several solutions to that, including collaborations with countries that do perform electron microscopy. Now, one of the things I wanted to point it out that we did discuss is that in certain situations in adults, one could consider treating an adult patient without a biopsy. The most relevant for today is the example of a patient who has normal kidney function, develops proteinuria, nephrotic range, and is found to be anti-phospholipase A2 receptor positive, suggesting that the patient has a primary form of membranous nephropathy. Although many of us think this patient should be biopsied as well, we do understand that some patients have severe comorbid conditions that would make them very high risk for a biopsy procedure. And as this diagnostic test is being developed and is accumulating evidence, we felt that if a person is at particularly high risk, it may be okay to initiate treatment without the kidney biopsy in these very specific and individualized situations. Okay, albumin to creatinine ratio and protein to creatinine ratio are helpful in general clinical management, but they're not sufficiently accurate for therapeutic decisions in terms of using high-risk medications. And as you all know, you can have proteinuria based on the pathogenesis of active disease, or you can have proteinuria with residual sclerosis and not active disease. So proteinuria is not necessarily a specific indicator that a disease needs to be treated. All of the estimated GFR equations that we use today and their corrected equations are included in the pool that have not been validated in specific glomerular disease populations. And so that needs to be considered in patients that are young, patients that are extremely proteinuric, etc. So this is another research agenda that needs to be carried forward. Now, proteinuria in certain kidney diseases, especially IgA nephropathy, has gained a lot of traction in terms of endpoint determination for example, the FDA in clinical trials. And this is taken from an article by Dr. Inker that was published in 2016. It's called a trial level analysis, looking at the treatment effect on proteinuria and the treatment effect on the clinical endpoint. And in this particular case, the clinical endpoint was the surrogate doubling of serum creatinine to represent end-stage renal disease, or the high probability of developing end-stage renal disease. And the various trials were analyzed, are shown as bubbles. The drugs that were tested are color-coded, as you can see, and then the impact of the trial in terms of N is based on the size of the bubble. But the point from this is that proteinuria reduction in IgA nephropathy specifically has been linked as a good surrogate marker of decline in renal function over time, so that abrogation of proteinuria, in other words, the treatment effect being reduction of proteinuria, can actually potentially be used as an endpoint. And this is part of ongoing discussions in the FDA. As well as other regulatory agencies. So if you see here this announcement, this was a change in albuminuria and GFR as endpoints for clinical trials in chronic kidney disease. And this is going to be, this particular conference involved the FDA, the National Kidney Foundation, the European agencies as well. And a consensus was reached, and these proceedings will be published in late 2018. But for specific glomerular diseases, the ability to conduct clinical trials with a shorter-term surrogate endpoint of proteinuria will likely be approved, and that should really open up the possibility of us developing new therapies for our various glomerular diseases. In terms of the general management of patients with glomerular disease, there's a lot of consideration of patient engagement in determining clinical trial eligibility. And in patient-related outcomes and measurements of what the patient thinks and how they think they've done with a new medication or with resolution of the disease. And surprisingly, as we talk to patients, things that we as nephrologists think are important, reduction of proteinuria, stabilization of serum creatinine, don't necessarily translate into how the patient feels or their ability to conduct their lives the way they want to. And so a number of patient-related outcome surveys are being developed and validated for glomerular diseases, as they have been developed in other areas of both nephrology and other diseases. So this is something that's evolving, and again, working mainly with the FDA, I know this is high on the list of things that the FDA would like to see incorporated in clinical trials in the future to get real patient feedback from the drugs. We did consider several other determinants of progression, some of which make excellent sense, but we probably tend not to ask these questions when we're talking to patients. Something that's relatively easy that probably has to do with nephron number and susceptibility to future progression is prematurity. In infants, many patients or their families will know whether they were born prematurely. Sleep disturbances can play a role in certainly in hypertension if you have sleep apnea, and this may play a role in progression of glomerular diseases. Obesity, as we know, is related with a secondary form of FSGS, and of course genetic predisposition. So these determinants of progression and outcome need to be factored in to the general management, although specific recommendations were not made at the meeting. The last part I want to talk about is this idea of futility. We really don't know how to define futility for our patients. It's often defined as an EGFR less than 30 or a kidney biopsy with high chronicity. But other things should be considered when looking at both on an individual patient basis, whether a patient should be treated or not, and also eligibility for clinical trials, because these patients are often excluded from clinical trials and they may actually show benefit. And so one consideration is for futility is to have a patient engaged in helping to make the decision whether or not they would want to participate or receive potentially cytotoxic treatments. The other things that are important is to understand how this GFR, the low GFR, came about. In other words, is this something acute that is potentially reversible, or is this something that's been progressing over many years and actually may not be treatable? In terms of the biopsy, while I'm a big fan of the kidney biopsy in helping us with our diagnosis and management, and looking at the biopsy is critical, in my opinion, it is only a small portion of the kidney, and if you happen to get unlucky and see an area of significant fibrosis, but this doesn't correlate with patients' GFR or clinical appearance, then maybe that shouldn't be a single factor that suggests treatment of the disease is futile. Also, one should take into account the patient's age and general wellness. These are important considerations because we know when we want to treat patients, we don't really know when we shouldn't treat patients, and sometimes I think we use these things not to treat patients, and I think this will be clearly elicited in the general recommendations in August. Moving to IgA nephropathy. A lot of discussion in IgA nephropathy, and what's exciting about IgA is that if you view this slide as kind of over the last many years, consideration of factors important to the pathogenesis of disease, there are a lot of potentially new therapies that are coming into play and are going to be trialed. Now I'm going to, okay, I'm going to go back one, sorry. I was trying to get a pointer here, but anyway, on the left, budesonide is a oral corticosteroid that is timed to release in the terminal ileum where the Peyer's patches are. So if one believes that possibly mucosal infections involving the gut can trigger IgA nephropathy, decreasing the immune activity in this region of the gut. The Peyer's patches, as you know, are part of the large immune response system of the GI tract, may be beneficial, and we'll show some data that was published in a phase 2 trial using the drug. Inhibitors of B cells are coming into play in the treatment of IgA nephropathy, BAFF inhibition or APRIL. These are growth factors for B cells and are necessary for antibody production transition to plasma cells, etc. The complement system, again, indicated in the lower left, although systemic complement activation is generally not a feature of IgA nephropathy, although this may be region dependent. In Asia, systemic complement activation can be observed more frequently than we see in our Caucasian patients. There is a lot of genetic analysis that suggests that the complement pathway is involved in the pathogenesis. There are some preliminary data on that, and there are several studies that are now looking at complement pathway inhibitors in IgA nephropathy. Proteasome inhibitors, which target plasma cells, are also being considered, and spleen tyrosine kinase inhibitors have just completed a phase 2 trial, and those results should be public shortly. And they also target antibody production from B cells. So we really don't know how to treat patients. This was Jürgen's trial, the Stop IgA trial, and it was published a couple years ago. What it showed was that immunosuppression reduced proteinuria, but did not necessarily change the outcomes in IgA. Now, this is a little bit different than what I showed you earlier with the proteinuria change leading to changes in outcome. And since this trial came out, it has been added to the trial level analysis by Leslie Inker to help us understand the true effects of improving proteinuria on outcome. What I thought was extremely important, a key lesson from the Stop IgA trial, was that there has to be a run-in period for IgA patients treated with conservative therapy, and by conservative therapy I mean excellent blood pressure control and renin-angiotensin-aldosterone system inhibition, because what this article demonstrated was that when this was done over 6 months prior to actual enrollment in the prospective part of the trial, where you were treated with an immunosuppressive or maintained on conservative therapy, about a third of the patients actually responded to conservative therapy in the run-in period and went into remission. So again, this will help us in the design and management of individual patients, but also the design of future clinical trials in IgA. The testing trial was a very large trial that was terminated early. There seemed to be a potential improvement in patients treated with corticosteroids in this trial, but there was a significant and large difference in adverse events that were important adverse events in the patients that were treated with rather high doses of corticosteroids, and so the Data Safety Monitoring Board stopped this trial early. Now, the trial has been redesigned. Lower doses of steroids will be applied. Appropriate prophylaxis for pneumocystis will be used, and the trial has started enrollment up again, so the results of this will be to be determined. This is a summary of the budesonide trial, the phase 2 trial that was conducted mainly in Europe and is now being readied for phase 3. And in fact, in Europe, phase 3 may be up and running, not so in the United States yet. But what this shows is over a 1-year period, the patients with IgA who had treatment with placebo, which was RAS inhibition plus placebo, versus the patients who were on RAS inhibition and received the slow release oral steroid. You can see that the steroid maintained EGFR over that year compared to a significant significant decline of patients treated with placebo only. These data plus the proteinuria change, which I don't show here, have really prompted the movement of this drug into phase 3. So this will be coming in the next 2 years probably, and should provide some interesting data for the IgA community. Membranous glomerulopathy, always controversial what to do now that we have a new diagnostic test that seems to track very well with disease. In terms of primary membranous nephropathy, an immune-mediated disease with antibodies to phospholipase A2 receptor, these are found in about 70% of cases. There may be some overlap with secondary causes of membranous, and so this is why biopsies still are relevant. There are other autoantibodies that are known, especially the THS-D7A. There is some suggestion of a correlation of that antibody with membranous in the setting of malignancy. So one should consider that if that antibody happens to be the one that's in your patient. And then there are likely to be other autoantibodies in membranous nephropathy that we don't know. In patients with nephrotic syndrome, the figure on the right is a little bit of an algorithm. It's not unreasonable with an index of suspicion that this might be membranous, a primary membranous, to obtain a serum level of anti-PLA2R. And if it's negative, then the patient should have a kidney biopsy and appropriate therapy based on the biopsy. If the patient is positive for PLA2R, as we said earlier, they deserve a risk assessment. If they can undergo a biopsy safely, they should have a kidney biopsy. If they are high risk for a kidney biopsy, possibly they can be treated. If they are high risk for progression, depending on the level of proteinuria and the length of or the duration of the proteinuria, they would deserve a kidney biopsy. If they're low risk for progression, so proteinuria that is not that high, other factors that are okay, control of hypertension, etc., they should be treated with RAS inhibition observed to see if spontaneous remission will occur. In membranous nephropathy, alkylating agents are still considered to be the drugs of use for patients at high risk for progressive disease. It was suggested that this be given by physicians experienced in the use of cytotoxic agents. Calcineurin inhibitors are known, as you all know, to induce remissions similar to cyclophosphamide, but they carry a much greater likelihood of relapse. Rituximab has been on the scene for membranous nephropathy, primary membranous nephropathy, for several years. We don't actually have the data out yet from the Mentor trial, which looked at cyclosporin and compared that to rituximab. But the initial data were presented at the ASN last year, and it looked like rituximab was more effective than cyclosporin in maintaining remission 2 years after enrollment. But what's a key point is that the non-response rate to rituximab was very high, at about 35%. So it's likely that the choice of therapy in the future is going to be determined by risk stratification modeling based on autoantibody levels as well as pathology. It turns out data are starting to accumulate to show that patients with lower lower anti-PLA2R may be more likely to spontaneously remit. Patients with very high levels may be very difficult to treat and may need cyclophosphamide, and patients whose antibodies develop epitope spreading has been considered, and those patients seem to be clinically more difficult to treat. So we would like to get some resolution with that on the Controversies Conference. Okay, minimal change, nephropathy, and focal segmental glomerulosclerosis were very controversial areas because these are both common in pediatric patients and adults. There's sort of a divergence in terms of what to do with the patients. As you know, children with nephrotic syndrome often don't get a biopsy. Adults often do get a biopsy, and the issue of genetic testing and when that should be applied did come up, and we hope that we'll be able to clarify that in the coming guideline. Steroid sensitive and steroid resistant nephrotic syndrome was felt to be important for the pediatric community, and that should remain. Primary and idiopathic FSGS will require clarification and revision. As I said, genetic testing needs to be clarified. What's important for adults with FSGS and minimal change disease is whether or not they truly need 4 months of high-dose steroids as first-line therapy. And as you know, rituximab is emerging as a very promising second-line therapy in minimal change disease. So this remains an area in flux and will require considerable new evidence to help us with the treatment. Lupus nephritis, several issues with lupus nephritis. The ISN-RPS classification, most people feel that needs to be redone. It doesn't consider tubulointerstitial or vascular injury, podocytopathies. So far, there's no clear benefit from genetic testing in patients with lupus. There is some indication that patients of African origin who do have APOL1 polymorphisms may have a worse response or more progression towards renal failure in lupus nephritis, but the risks and benefits of APOL1 testing uniformly in lupus it has to be clarified. There are emerging and continuing data suggesting that patients with clinical remission still have histologic activity. If one were to look at the biopsy, doing a repeat biopsy, and the opposite situation is true. Patients can have proteinuria for several reasons that don't include active inflammation, and so a biopsy can show no histologic activity, but clinically perceived as still being active. So the role of repeat biopsy in lupus is under consideration. Proteinuria at 1 year is still currently the best predictor of long-term outcome. Many folks are working on biomarker panels to accurately stratify risk, predict flare, and monitor treatment, but to date there are no biomarkers ready for clinical use. The lupus group recommended antimalarials for all patients with LN, obviously watching the retina and making sure the patients can tolerate. Cyclophosphamide and MMF are the gold standard for remission induction. Calcineurin inhibitors are increasingly being investigated. Most of the studies are from Asia. There are now studies including a phase 2 trial that was multinational that also suggested, in its at least in abstract form at the ASN, that a multi-targeted approach may be beneficial in patients with lupus nephritis. Refractory lupus, is a problem for all of us. One of the very most important things in patients who are refractory is to verify that they're actually taking their medications. As you all know, these are young patients. The medications have significant side effects on their appearance, and sometimes even though they note that they are taking medications, they're really not. So checking levels of medications can help you decide if the patient is really being adherent to the regimen. MMF is one obvious example. Hydroxychloroquine levels are now available as well. If there's concerns for a patient developing a different diagnosis in terms of being refractory or losing kidney function, a good example of this is a thrombotic microangiopathy. Consider a repeat biopsy. Obviously, we tend to switch from mycophenolate to cyclophosphamide or vice versa if a patient is not responding to the initial choice of standard of care induction. The ideas of adding or changing to a multi-targeted approach with calcineurin inhibitors has been suggested for refractory disease. There are a lot of data, albeit not randomized controlled trial data, suggesting the addition of rituximab may help, and of course continued use of cyclophosphamide is potentially to be considered, but one needs to watch the cumulative dose because of the possibility of future malignancies. There's minimal evidence outside of a small series and case reports on intravenous immunoglobulin, plasmapheresis, and these need to be explored. To get to the last topic before we open up for questions, a lot of discussion on ANCA vasculitis because of the new developments over the last several years. ANCA serology and biomarkers. We do know that MPO versus PR3, ANCA has predictive value with respect to outcome and risk of relapse. PR3 ANCA patients being especially prone to relapse. It is recommended that ANCA be divided into MPO and PR3 rather than clinical descriptors. New biomarkers were considered and mentioned. These have come mainly from the large ANCA trials like RAVE and have shown some utility, but they haven't been validated in independent cohorts yet. In terms of initial treatment for ANCA vasculitis, we do recommend biopsy to investigate the extent of kidney involvement, help with prognosis. The choices of initial therapy are still cyclophosphamide, but now rituximab, both with glucocorticoids. If the patient hits remission, then recommendations are azathioprine for a maintenance therapy or rituximab for maintenance therapy. And rituximab for maintenance therapy at least has some evidence that it may be better than azathioprine. It's not clear really what the duration of maintenance therapy should be. And it is also not clear whether rituximab should be given in a fixed schedule or based on when B cells reappear. In refractory disease, switching from cyclophosphamide to rituximab or vice versa is suggested. For a severe ANCA-associated vasculitis, patients with severe kidney disease, creatinine above 4 milligram per DL, and or pulmonary hemorrhage, cyclophosphamide is recommended. Rituximab with glucocorticoids is listed on this flow chart, but as you know, the RAVE trial did not include patients who had rapidly progressive kidney involvement, and the rituximab trial did use rituximab successfully in these patients, but also treated concomitantly with several doses of intravenous cyclophosphamide. That remains to be clarified. The addition of plasmapheresis is still controversial. And then if the patient can be brought into remission, the same sort of maintenance regimens should be considered. Let me move on just to this. It's truly unclear as to how to treat ANCA vasculitis with rituximab. There are several induction regimens that have been used. There are several maintenance regimens that have been used. These are all taken from the literature. So you see there's quite a bit of heterogeneity in the approach to using B-cell depletion for ANCA vasculitis. It is relevant because of the cost of the particular medication and the monitoring, especially in the maintenance phase. And so these are clearly issues that need to be sorted out in the future. What's interesting is there are new therapies on the horizon. This is taken from a recent publication in JASN, looking at complement inhibition. This is a C5a antagonist. Avacopan, it's given orally. Patients were induced with cyclophosphamide or rituximab, and then they were either given placebo and the usual dose of prednisone in the left panel, and then the complement inhibitor plus either a low dose of prednisone or absolutely no prednisone, which is remarkable when you consider treating ANCA vasculitis. You can see in this particular plot that they're looking at the Birmingham vasculitis score and improvement in the score over time, and you can see that the addition of the complement inhibitor with or without prednisone improved the score much more rapidly than patients treated in a traditional fashion. How do I interpret these data? It suggests that complement inhibition in this particular with this particular drug may actually be steroid sparing for ANCA vasculitis. These data prompted a large phase 3 trial, multinational, which is ongoing. So hopefully in the next couple years, we'll have these final data as well. So I think that's the last slide. And I think we can open this up to questions and discussion.
Thank you very much, Brad. Great job in summarizing an extensive content.
Thank you.
Yes, so there are a few questions. I can see 8 of them, most asked by Dr. Ivan Vucina from South America. So the first question is, what do you think about research of Professor B. Hellstrom using budesonide 16 milligrams in an IgA nephropathy? This work was done with about 250 IgA patients, and they show reduction of proteinuria and lowering speed to ESRD.
Yeah, that was one of the important trials that were considered this past year. That is, as you know, now becoming a phase 3 trial, multinational, that will be conducted to verify. Those data were taken to the FDA, and a plan was put forward to get the drug approved based on a proteinuria surrogate endpoint. So that's very exciting, and I think that what we need to do is get the trial up and running, and then we'll have the results. Of course, proviso in this trial, at least for the FDA, is that proteinuria can be an endpoint, but after proteinuria, the patients have to be followed for several years to demonstrate that the reduction in proteinuria actually had an effect on slope of EGFR decline. So while I'm very encouraged about this trial, and just for transparency, so you all know that I am on the advisory board for this trial, and this coming summer we're having our next board meeting to try and get the trial initiated. I think that it does have potential, and I think it will be a very interesting trial, and I look forward to enrolling patients in it.
Just to jump in here, at least in Europe, this trial has lifted off the ground already. I think the US is still pending, as Brad says. And the trial will be called NephIGuard, and hopefully will be done in the next 2 to 3 years, at least as far as preliminary data is concerned, that will allow FDA to formally license this, with then, as Brad said, a formal follow-up period looking at GFR.
Thank you, Brad. Thank you, Jürgen, for your comments. Another question by Dr. Mario Rovin is, how are we going to deal with sampling error as a hurdle in the assessment of chronicity? Not all pathologists agree with the degree of interstitial fibrosis being described. Also, how are we going to deal with this as well?
So that's a really excellent question, and something I enjoy thinking about. I pretend to be a nephropathologist sometimes. I think that you're right. How to assess chronicity simply by light microscopy is really subjective, and many of us would like to see this become a much more objective measurement. Now, there are some stains that do reflect fibrosis, and it's something conceivable to me as we enter the age of digital nephropathology, talking with colleagues at different institutions, that if we can develop specific staining for fibrosis, the computer can actually quantify this and give us measurements as to area per interstitial volume. And I think the next thing we would need to do is to take these actual quantitative estimates and look at this in terms of renal function, but it would have to be done in a serial fashion. The other thing that I think is really important to point out is that there are biomarkers that are starting to show some correlation clinically with chronic disease and progression. I'm going to point to epidermal growth factor, which was presented a couple years ago at the ASN. I will suggest that this is not simply restricted to proteinuric kidney diseases like FSGS. We have just finished a study. We just sent the abstract in. As you all know, ASN deadline was yesterday, looking at this in lupus nephritis. And I don't want to describe the whole abstract because it hasn't been reviewed yet, but suffice it to say that measurement of this particular biomarker in the urine was highly associated with fibrosis on the kidney biopsy. Now, why would that be more important? Well, I think all of us will agree that we occasionally see fibrotic areas on a biopsy, and it doesn't seem to correlate with what we see clinically in the patient. And you know, the biopsy is just a small portion of too large parenchymal masses. So ultimately, I think the answer to understanding chronicity is not simply going to be the visualization on the biopsy, but I prefer a urine biomarker, although some people would suggest serum might be okay. But a urine biomarker that reflects an integration of chronicity or activity of a disease from both kidneys and the entire parenchymal mass. So I think that area of biomarker development really is starting to bear some fruit. And I think that this is something that many of us are looking at actively in our laboratories. And I'm not going to say that this is going to be part of the actual guidelines that come out in August, because probably still not ready for clinical use. But suffice it to say that this is really coming along, and I'm very encouraged by the data I've been seeing.
Okay, thank you. Another question by still Ivan Vusina is regarding tonsillectomy, and he's asking why is it applied only in Japan?
I'm sorry, what was the word?
Tonsillectomy. Tonsillectomy.
Oh, tonsillectomy. Well, so the studies in Caucasian, Jürgen's going to help me in this, because as you all know, he's an expert in IgA, and I like lupus nephritis as my particularly favorite GN. In the USA, tonsillectomy studies did not really bear fruit or show a difference. But in Asian patients, and I think the tempo of disease in Asian patients of IgA is a little bit different than other ethnicities. And Jürgen, can you help me here?
Right. I think there's currently no evidence that tonsillectomy has a role in Caucasians unless you have one tonsillitis after another, and thus a trigger of innate immunity, which we know triggers glomerular disease. In Japan, there was a recent randomized controlled trial on tonsillectomy, which showed a very small proteinuria effect of tonsillectomy, but no effect on GFR. So even in Japan, the evidence that tonsillectomy really affects the cause of IgA nephropathy isn't there.
All right. Other question is still regarding Dr. Hellstrom study, and it says that Dr. Hellstrom conclusion was that using oral budesonide 60 milligrams with ARIS blockade, showing that one drug acts specifically on IgA nephropathy. This is more of a comment. I don't know if you have anything to say on that. Otherwise, we'll just move on.
I don't have anything to add.
Okay.
Well, I think one should stress that this, of course, is not really specific for IgA nephropathy. It's an interesting new approach.
Okay. Other question is, can you follow treatment of membranous nephropathy measuring levels of PL2R in blood?
That's an excellent question, and I very much want to say yes. I think we still have to prove that with certainty. The data that we've seen so far show that in patients who eventually respond clinically, we generally see a decline, a preceding decline in the serum levels of autoantibody. And of course, the rationale or the pathophysiology of that would suggest or be anticipated that if this autoantibody is causative, that your therapy diminishing that autoantibody would be required first, and then we would expect healing to occur when autoantibodies no longer interacting with the podocyte, and that would take time. So the answer is, or at least the answer for me is, in my own practice, and again this is what we do here, is that we do tend to follow autoantibody levels to assess how our treatment is doing. One important reason for that is, as you all know, unless you give calcineurin inhibitors and proteinuria disappears very quickly, and some of that effect is not necessarily due to an immunologic effect of the calcineurin inhibitor, but maybe hemodynamic or direct acting on the podocyte. But let's say you use a traditional therapy like the Ponticelli protocol or a variation. You can give that therapy, and then you need to wait several months to see a resolution of the proteinuria. What's important to me is that one gives the therapy and sees a resolution or a downtrend in the autoantibody, because if that hasn't occurred, then I don't think you can anticipate resolution of proteinuria in the future, and you might need to consider that the disease was refractory to your treatment and a different approach. Now, that's opinion-based more than evidence-based, although those data are emerging. Like anything else, you and I in our own practice have seen patients in which this does not necessarily apply, or the converse does not apply. More often the converse, which is if you follow patients who have done well in membranous with therapy, and then you see the PLA2R antibody climbing again, that is not necessarily correlated with reactivation of the disease, and we don't have sufficient data to say you should treat that in a preventative fashion. So I think both sides of this question, the question you asked and the question I just raised, really do need more consideration, more evidence-based consideration. What we hope to do, what we will do in the August meeting, is have all of these data available and put it together to summarize where we stand right now using the PLA2R as a diagnostic or a prognostic. And I think that will be extremely useful for the community, with the caveats of things like I just said. So that's coming, but I do actually check the levels because we actually have them fairly readily available for PLA2R, not for any other autoantibodies in membranous, however.
Okay, thanks. We have just about time for 2 more questions. First one is, what is the recommended regimen of RTX for MCD, FSGS, and MGN? Do we monitor CD19 in these 2 conditions?
In using rituximab for minimal change disease
and FSGS
and FSGS. So, okay. So, all right. Let me off the bat. I think the data for rituximab and FSGS is very much less robust than in membranous and minimal change in kids. So I'm not sure where we're going to go with recommendations on that in August, but my feeling is that there will be insufficient data really to make a coherent recommendation for FSGS. In kids with minimal change disease, the data seem to be better. There are some data in adults. I don't know how we're going to design the specific recommendation, but to answer your question, sort of in a scientific way, the way I would approach it is, until we know how these drugs really work in these diseases, and I'm going to include membranous in this as well, until we really know, I think gathering as much information as possible in a prospective fashion, if you will, and having that information available for us to look at as a community, in other words, publishing it, is really important. So I think that if I were designing trials, looking at these drugs in those diseases, I would definitely look at B-cell CD19 counts. Okay. In the individual practice, I also would do this because I tend to learn from each experience with a patient. And the problem that I find is that the ability to do CD19 counts really is dependent on your institution. At my center, for example, I cannot simply get a CD19 count. I have to do entire flow cytometry, which is very expensive, and it adds considerably to the cost of testing. Other centers can do CD19 counts. For example, the Mayo Clinic does just the CD19 count. So I think we have to be a little bit cost conscious as well. But certainly in the context of developing these therapies for future use in clinical trials, I think looking at CD19 counts is prudent.
Okay, and very last question. This is actually a question that was asked by two participants. Is, have the results of the Paxivus trial reported last week at the ERA EDTA Congress already been considered in the flow chart given for AAV?
Okay, I was not at the Congress and I have not seen the results. Jürgen, were you there?
I just know the data indirectly, but what the data apparently show is that plasmapheresis adds something when you have severe pulmonary hemorrhage, but in all other instances, there was no clear benefit. But we need to see the data being published, and I assume that will happen fairly soon so that we can incorporate those in the guideline revision.
Yeah, I agree. I think this is a really, really important question that many of us have been waiting for the results of this trial. I'm excited to hear that they were presented, and hopefully they'll be published soon so that we actually can use this in our evidence-based review in August, because that is a question that's been really sort of hanging for several years now.
Okay, I believe we've made it perfectly in time. Thank you for your questions. Thank you, Brad, for your excellent lecture. And I hope that you got the flavor of this conference out of this webinar. Thank you all for participating. Bye-bye.
Goodbye, everybody.
Thank you, Brad. Thank you, Jürgen. This was a very interesting webinar. If I know not all questions have been answered, so if you want to have more information, please write to the email address on your screen, education@disn.org. And also, lastly, you might know that the Nephrology World Cup was launched today. Just follow the ISN on the ISN Education Facebook group or on Twitter. Just look for the hashtag Nephro World Cup and enjoy.